computer, just in case if there's a glitch with the live streaming. But we're gonna get it started. And I really want to thank everybody for being here today. This is the International GBM Awareness Day. And I think you can see my single slide screen at the present time. Is that right? And it is my pleasure to be representing the tumor section, and that is the American Association of Neurological Surgeons, Congress of Neurological Surgeons section on tumor. I am the current chair, and today I have distinguished faculty to present on glioblastoma, and we'll introduce each of you in just a minute. I think that is important to remember that we as an organization exist with the mission of providing a forum for education, research, and advocacy for patients with brain and spine tumors. Our organization is actively involved in coordinating activities and programs related to brain and spine tumors. And those include, but they're not limited to, clinical trials, research, and education. And clearly, glioblastoma is a big item on our list. As I said, today we'll have experts that will share their professional experience on this disease. And the one topic that we will be starting with is the role of surgery in the care of patients with glioblastoma. Yesterday, somebody asked me, we just had a brain tumor awareness month. So here in the US, the awareness month is in May. I know that in the UK it's March, but in any event, it was recent. And so why do we also need a glioblastoma day? And here are some data. The National Cancer Institute Surveillance, the SARE program, estimated that approximately 18,000 people in the US will die from brain and other nervous system cancer in 2022. So clearly it is an important disease. It is one that we need to be aware. But so since we just had this full month, why do we want to join forces today in this International Day? And I think that there is a very good reason for that. So let's look at the definition of what is a primary brain tumor. Primary brain tumor is a tumor that starts and occurs within the brain. The annual incidence, as you see in the slide, is approximately 20 over 100K. 30% of primary brain tumors are malignant. And among those, glioblastoma is the most common one. How are primary brain tumors being diagnosed and classified? The classification goes all the way back to the beginning of the 1900s with Bailey and Cushing. And subsequently, many years later, it was changed to the WHO classification, where histological criteria were taken into account. And then recently, it was changed to include genetic and epigenetic changes, or as some people say, molecular parameters. And those are very important, and that are here on the slide. And there are some that are predicting a more favorable outcome, including the IDH mutation and including the methylation of the 06-methylguanine DNA methyltransferase MGMT promoter. So glioblastoma deserves a special day because it's a very aggressive tumor. It is infiltrative in nature, and approximately 95% of glioblastomas do recur, or as we defined recently, progress. And it is a progression because what we believe is that the actual disease was never really removed to start with. They occur in people that are in their 40s, and here you see Beau Biden, our current president's son, and we see Senator Kennedy later in life, both individual affected with glioblastoma, so two peaks in the patient's life. And there are some factors that are influencing outcome, and surgical resection clearly plays a big role, and we surgeons believe that that is the case. And so today, I think I would like to try to answer two questions. How do we quantify resections? And does the extent of resection result in a different outcome? And if yes, what do we mean by outcome? Does it make the patient survive longer? Does the outcome also include better decreased symptoms and possibly increased quality of life? So extent of, we define what a glioblastoma is, and now we're going to go try to define what is extensive resection, what do we mean by overall survival, and whether or not there is a difference between a diffuse glioblastoma, the glioblastoma that goes through across 2 hemispheres, what is the impact of age, and whether or not there is anything that we can do to optimize that intraoperative guidance resection. So here are all the resections that we can find in our literature. And today we talk about gross total resection. So for glioblastoma, gross total resection is a little bit of a oxymoron because I just described that the tumor is infiltrative. So when we talk about gross total resection, what we mean is to go around with a pen where the enhancing borders are, and in the postoperative image show that that enhancing area was removed. That's what is referred to by gross total resection. As I said, we know that there is tumor that is left behind. How do we measure that gross total resection? The MRI needs to be done within 72 hours after the surgery. If we do it later than that, there are postoperative changes that might mask what the real resection is. And it's best done with volumetric sequences. And there is emerging evidence saying that it's even better if we can use some sort of computer software and or AI. And then the question is the question to answer is, what do we mean by extent of resection when it's not gross total? Do we mean that is a proportion of the preoperative volume, or do we mean that is the absolute residual of the tumor that makes a difference? And I do not have a good answer for this. I don't think that the literature is strong enough to help us replying, but we will walk through them. So as an aside here, since I will be talking about guidelines, what are guidelines, right? So in the 90s, there has been emphasis by the with the field that is called the evidence-based medicine in trying to analyze the published literature and provide what we call evidence. And you see here in the picture and in the prose what class evidence is. So clearly the best possible class is class 1 with 1 or more randomized controlled trials. And that is very difficult in neurosurgery, and it's very difficult for glioblastoma. So most of our evidence will be on class 2 and 3. And if it's less than class 3, we say that there isn't enough evidence to really provide a recommendation. So recommendations stem from the evidence of the literature that has been published. And when we put them together, we call that publication guidelines. This is totally different than other publications that are called consensus, like the American College of Radiology has a lot of these, some of the international communities publish consensus, and that does not follow this methodology that I just described. Today, there are 2 guidelines that I would like to show you a little bit, tidbits of the results. One is the update on the newly diagnosed glioblastoma, and the other one is the update on the recurrent glioblastoma, and in particular, the role of surgery on each of the 2. So this paper was published in 2020, and you see here that in the part of the guideline that where we looked at the cytoreductive surgery, we show that there were actually quite a few citations that were screened for eligibility. Ultimately, 51 studies were able to meet all the criteria for the inclusion. And the answer to the question, what is the effect of extent of surgical resection on patient outcome? The level of recommendation was the level 2, and that is that maximal cytoreductive surgery is recommended in adult patients with suspected newly diagnosed glioblastoma, with gross total resection defined as removal of contrast enhancing area. So this is what I showed you in the first couple of slides. There are a number of studies that looked at residual burden of tumor, with a preponderance of study demonstrating that this was predictive as well. In other words, that a very small amount of residual tumor has a positive impact on overall survival. And so then since I told you that these tumors are infiltrative, the question that multiple neurosurgeons have been asking over the years is, why don't we do a supramaximal resection? Why don't we resect more than just drawing that line around the tumor? And so if you wish, instead of having a postoperative MRI that shows the blue circle with a supramaximal, you will go above and beyond obtaining that red circle. Now, when we looked at the published literature, we did not find any conclusive evidence that a supramaximal resection is advantageous for overall survival. As a caveat, just a reminder that all these guidelines are based on past evidence, so I cannot tell you that in the future that evidence will accumulate, but it's not here in 2022. Now, the concept of maximal safe resection has been proposed and suggested, and I think it's a very important one to remember, because we want to preserve function. We know that there is a definite impact in preserving function on quality of life, and we also know that aggressive resection result in longevity, increased longevity, increased overall survival. And so we feel that if we can preserve the quality of life of that patient will have a win-win situation. Now, with the symptoms prognosis, whether or not our surgery can result in a decrease in symptoms, there are papers in the low glioma literature showing that that is the case. In the glioblastoma, I think that we're still there in the process of accumulating evidence. I think that there are multiple patients that do have that clinical advantage. Here is an example of a 55-year-old woman presenting with the left upper extremity weakness, difficulty speaking. I'm not sure if you can hear this video, but you can see that she has this left upper extremity weakness. You can see that she has difficulty enunciating words. And so what we did for her was recognizing that this was most likely nested in front of the speech area, but abutting the phonation muscles, and therefore in a pretty fortunate situation where a gross total resection would be possible, as it is the edema that is giving her most likely the neurological symptoms. And so you see her in the office 7 days after surgery. I don't shave the hair, so you don't see the scar. You see that motor weakness is resolved, and she had very fluent speech, and this is the postoperative MRI. Now, that surgery was done with intraoperative monitoring, not just to look at AEDs for seizure foci, but in particular to look at SSCP and making sure that our interpretation of the images was correct, and this was a safe resection. And as I mentioned, in glioblastomas, the majority of them is de novo, so grows very, very rapidly. Instead of having this infiltrative situation, you have situations where the tumor is deviating by putting pressure on the fibers, and or the edema is putting pressure on the fiber. And those are very favorable situations where you can correct the neurological deficit. Here is the question about the butterfly glioblastoma. In the previous guidelines, the evidence was not there to support the resection of these tumors. And in this particular guideline, we show that instead, if there is a bifrontal butterfly glioblastoma, a resection is suggested to improve overall survival, as opposed to biopsy alone. As you can see, there were a number of limited studies, and it appears that the KPS significantly affects the overall survival. So once again, quality of life is very important. And so now is the question about age. The age is usually the cutoff for the age is 65. And you see here that in this latest update, we show that in elderly patient, there is benefit for a gross total resection. There is a little detour that I would like to take about this, the cutoff of 65. This was placed in the 60s or 70s when the life expectancy was much lower than it is now. And so if you look at these graphs, in 2050, there will be approximately 2 billion people that will have, that will be over 60. And so the question is, can we move that age cutoff to greater than 65? And I think that there is abundant evidence in the literature showing that indeed the population above 60 has shown a decrease in mortality rate for surgical interventions, as well as decreased length of stay in the hospital. And so most likely we will see that more trials will include patients that are of older age. And so I would encourage this audience, if you have somebody that has a good performance, not to just base it on the anagrammatic number that you see on the date of birth. And so I think that the direction for the future is where to draw the line, and that line will be drawn probably much higher than 65. And here is the recommendations for the progressive glioblastoma. In this particular one, what we looked at, you see the number of abstracts we started with, and we were able to come up with a level 2 recommendation that cytoreductive surgery is recommended for symptomatic patients with progressive glioblastoma. Again, the word progressive is better than recurrent, because we believe that the disease has been there all along, except that had been controlled by multiple treatment, and finally it blossomed to the point where another surgery was necessary. So how do we optimize extent of resection? Intraoperative guidance is very important. I think that we're all very familiar that the left side of the slide is pertinent to a beautiful acoustic, whereas the right side is pertinent to an intrinsic brain tumor. You cannot see where it is, and one that you localize the tumor, you don't know where to stop necessarily, because it all look very similar. And so intraoperative guidance with computer-assisted navigation is important. In this latest guideline, we show that both intraoperative MRI and 5-ALA are reach a level 3 recommendation that we suggest that should be maximizing the extent of resection. Now, other technology that are more available worldwide, like ultrasound, did not accumulate that amount of evidence, but clearly there are a very good armamentarium in practice. And similarly, other fluorescent agents do not have enough evidence yet, but it's accruing, it will accrue in the next years. The last word is on radiosurgery. Radiosurgery clearly is not a treatment for upfront glioblastoma. We and others have published on its use. So this paper we published 10 years ago or so on very focused disease. Here you see an example of a patient that operated on, had a successful resection, and then recurs above the cavity months later. And this is an ideal target for radiosurgery because it is very small and falls within those parameters. So there is more to this that needs to be studied. As you see, this was a fortunate scenario, and those presented in that case study was also very similar to this. So how to select patients, I think, is very important. And so in conclusion, I would like to say that high-grade gliomas are a very heterogeneous group of tumors with different molecular signatures. That glioblastomas are those that are recognized either by histological and or molecular characteristics. So nowadays you can have a patient that has a histological diagnosis of a high-grade glioma, and yet the molecular features are those of a glioblastoma. So that patient falls within the glioblastoma category. The extent of resection is favorably having a favorable impact on survival, quality of life. That we need to remember that the patient performance is very important, therefore to maintain it. And this is why a maximal safe resection is what we have to aim for. Finally, that intraoperative guidance is indicated and desirable to obtain that resection that we are striving for. And so with that said, I will conclude, and I will ask if there are any other questions. Okay, excellent. I don't see any burning question at the present time. And so I think we can continue on and ask Professor Casper to continue with the next presentation. In the way of introduction, he is well known internationally. He's serving on the executive committee as the co-chair for the global neurosurgery. And you're showing us your email, X. Okay. And he has published over 200 articles, been involved in multiple national and international committee. So it is really my pleasure to have you today, Ek. Thank you.
Thank you, Isabel, for your kind introduction. So I would like to contribute to today's webinar with a talk about perioperative imaging strategies for glioblastoma. And I want to make this sort of personal based on the last 10 cases that I came across, and try to explain to the audience at the level of interested colleagues or fellows, why do not all patients get the same imaging pre-op and post-op? And why do we not always use the same tools for all patients that come across our clinical path? Because I really want to ensure patients also, not everybody needs every single technology that's on the market to still get most appropriate care. I think afterwards, Dr. Agi will go more into details about the intraoperative management, and I hope that my talk can lead into this. So I have nothing to disclose other than that I work in a number of interesting institutions. Who is interested in can follow us. My agenda for today is diagnosis and imaging for glioblastoma. Briefly, how we organize a brain tumor program for that purposes, and an imaging algorithm. And really the core here is to show you some case vignettes for a successful practice. Those interested in summary, I've published recently a paper on pre-surgical and surgical planning in oncology for maximum safe resection, and that's available for download. So the first credo that I want to share, similar to what Isabel said, is that all patients should really be seen by a tumor team in a brain tumor center, because a strategy is best developed not from one single person's perspective. Multiple eyes see multiple things and have more than one good idea. The creation of a patient-centered care flow is best from the patient's perspective. And I think the way to organize this is that every case, even the pre-surgical cases, should be discussed at a weekly morning conference for review of the patient's presentation and all next steps for elective patient workup and treatment. And then patients are seen jointly between the brain tumor patients and the brain tumor team. And for on-call patients, we implemented a rule that all the faculty members within 24 hours will stop by the bedside, so that the patient is reassured that they get care from the whole team, not just from a single provider who happens to be on call. We organized the brain tumor program here with the Dana-Farber as a comprehensive program. We have written little pathways for this, and it's really a multidisciplinary endeavor where all of us try to counsel one another, and then afterwards the patient at the bedside to get best possible outcomes. So how do we diagnose tumors? And Dr. Germano pointed this out. We can do this radiographically and get a first idea about what we are likely dealing with. But the gold standard is really to diagnose tumors based on tissue. And therefore, this presentation is an ex post presentation. I present clearly identified glioblastomas by histopathology, but most of these we assume to be glioblastoma prior to surgery. What is a typical algorithm for patients that show up? Well, if the tumor is an incidental finding, and that means if the patient, let's say, fell down a set of stairs, gets imaged in the ER, and there's an unusual spot on the CAT scan, often patients don't end up in a brain tumor center. They are followed by a neurologist or by a primary care physician. And if the patient is truly asymptomatic and stable, the minimum I think one should do is obtain an MRI scan to better characterize the soft tissue of the brain. If you have a set of films that designates a tumor, you have to make sure the patient gets follow-up. And if the lesion is progressive, one needs to add in further imaging modalities, MRI scan with and without contrast, CTA, and sometimes others, to make sure we understand the lesion we are dealing with. More typically for a neurosurgeon, it's a non-incidental finding in a patient who is symptomatic. Let's say the patient had a non-febrile seizure, comes to the attention to the hospital, and there's a lesion identified in the ER, such as this one that you will see in larger images in a minute. The patient really should be seen by the tumor team, not just by a single provider. If the patient is for whatever reason non-surgical, one should still get images because there are non-surgical treatment options available. And if the patient is surgical, and I consider all brain tumor patients surgical until proven otherwise, we have a lot of different technologies available. These are the basic brain tumor imaging technologies we have. We have CAT scan with and without contrast with a variety of options. We have different MRI sequences. We have CTA, CAT scan angiogram, and CT venograms to characterize the lesions. We have formal angiograms to characterize the lesions. And most of the time, this set of imaging will tell us in 90% of cases, roughly what we are dealing with. And most glioblastomas are quite well picked up by imaging. In those cases that we take to the operating room, we then add in perioperative, preoperative planning tools, such as our image guidance sequences. I often use MRI 3D surface rendering to see where's the surface pattern of the brain when I open up in relation to a deep-seated lesion, so I know where to best approach the lesion. I may not always use the classic sequences to do resections, and I'll show you in a second why. And I very frequently use functional imaging, which is a special tool where you can use the oxygen consumption of the brain to identify active areas of the brain that have specified functions. I also use tractography in almost all tumors resections at this point in time, because it tells you where the fibers are, and if the fibers are displaced in a peculiar way, you can pick unusual entry points to avoid disrupting fiber tracts. Now let's go through a couple of cases. So this is one that I would consider a simple lobar right frontal glioblastoma. Patient came to the ER with some headaches, was imaged, had a large lesion in the front. Those patients in my practice all get an MRI scan and a CTA. The CTA to understand vascular supply and where's your best control over the lesion. MRI to understand extent of disease. And you can see a large ring enhancing lesion in the frontal lobe, but it is limited to the frontal lobe with the contrast enhancing portion of the tumor. The flare image, which represents the swelling as well as infiltrative disease, is significantly more extensive. I took this patient to the operating room with those two images alone. I just needed an MRI scan and a CTA to do a frontal lobotomy, microscopic, navigated with closure techniques. And we were able to achieve a near total resection. What you see down here is a largely Surgicel that is a little bit blood-soaked post-operatively, but the only residual really is this 5mm contrast enhancing portion that goes into the corpus callosum that I did not want to resect. So here we had a near total resection with greater than 97% of tumor being removed, and the patient had an excellent clinical outcome. The same is true for a simple lobar right occipital glioblastoma. This patient came in with some headaches and some visual signs. The patient was imaged in the ER, had this heterogeneous lesion in the back. We decided to get an MRI scan showing again a heterogeneous lesion, ring enhancing in the occipital lobe only. CTA shows that the lesion is a bit hypervascular, but not too bad. So I can do this operation with 2 scans only and can do it safely. Took this patient to the operating room and did a lobectomy because there's no point in leaving a small piece of infiltrative tumor behind in the occipital lobe if you have decored it and it's no longer functional. So doing a lobectomy allows you to remove the tumor in toto and reduce recurrence. And the patient had complete resection of contrast enhancing material with just a small visual field defect. In this case, wasn't so small, to be honest. It was almost a hemianopia, but this was worthwhile. The patient had no other neurological concerns. Next case. This I consider a complex left frontal lobar GBM. You see that this patient has multiple contrast enhancing lesions on MRI scan in the left frontal lobe. It is coming closer to the speech area, which is located in the left frontolateral portion of the operculum. So here I added in a functional MRI scan to make sure we are not getting anywhere near the area. We could see a clear separation plane with the sulcus separating out the tumor area from the lesion, and we did a nice cross-total resection of removing the frontal lobe without any residual, without any concerns. Next case, this is a recent case that is significantly more difficult. There was a patient who presented with a seizure around Christmas that was imaged at an outside facility, and they saw a small non-contrast enhancing nodule temporally. You can barely recognize this on an MRI scan that isn't made for brain tumors. It was non-contrast enhancing, but it showed up on the flare, and it was DWI bright, which means it's a cell-dense tumor in this location. The patient just scheduled the patient for follow-up with the neurologist. Before she made it to the neurologist, she seized again, and 4 weeks later, the lesion already shows a little bit of contrast enhancement in the temporal lobe. So this is a glioblastoma developing under your vision, under your visual control. When she came to me 2 weeks later, it was clearly contrast enhancing, had developed a second focus on the flare imaging. I obtained pre-surgical flare images in all 3 planes that show significantly better the delineation of the tumor, was nicely located in the middle temporal lobe, laterally only. I got functional imaging because she was bilingual, and bilingual patients have bilateral representation of languages. I wanted to make sure that this is not involved in my resection strategy. It was not the case. I got the CTA showing a hypovascular tumor, not too bad for resection. So I took her out to surgery and just did a lateral temporal lobectomy with the posterior margin of the flare included in this resection to make sure that I had resected all visible tumor on flare, and we had an excellent postoperative outcome with no residual disease. Now, this is again a not so simple lobar left temporal GBM. This is a case that came through the ER with the patient who had headaches and was imaged with a large tumor, a lot of edema in this case on the CAT scan. When he got the CTA in the ER, we saw a large amount of vessels, and the concern was, would this be a tumor, or could this be actually an AVM, or could this be both, right? I had once before encountered a tumor that occurred in the same setting with an AVM. So here I decided I do need additional imaging. I got the MRI scan showing extensive edema, but a relatively small contrast enhancing anterior temporal lobe lesion. So here I decided this is not good enough for imaging. I wanted to get a DSA, a formal angiogram, which is very rare these days in tumor surgery for intrinsic brain tumors. We showed that there was no blood supply from the right side, but clearly a tumor blush from the left side. And to our surprise, there was significant tumor supply from the external carotid, which we could embolize to shut down blood supply to the tumor. That made the surgery much safer and much faster. We were able to do an anterior temporal lobectomy without any concerns, without residual disease, and the tumor went home. The patient went home on day 2 after the tumor resection. Case 6 is a different problem. This is a patient who had a previous left-sided tumor resected, and she came back with new onset seizures during follow-up. Here we could see recurrent contrast enhancing disease in the temporal lobe, but to our surprise, the patient had symptoms that seemed to be more significant than this. And because she came in on the neurology service, she happened to get a stroke workup with a perfusion study. Here on the perfusion study, you see the entire temporal lobe is hyperperfused, reflecting infiltrative disease. So here, instead of taking just the contrast enhancing lesion out, I decided I get the CTA, I get the MRI scan, and again, I performed a, temporal lobectomy, removed the entire tumor, both the contrast enhancing portion and the medial portion, to make sure that there's no residual disease, and the patient had a good outcome. Now, this is now advanced tumor imaging for more complex cases. This is again a not so simple temporal glioblastoma on the left side in a highly functioning patient who just had word finding difficulties. He got the normal MRI with contrast pre-op and a CTA, which I show in a second. But because the lesion is just under eloquent area, under the speech area that comes in 2 packages, speech production is in front of the tumor, speech understanding, word finding, receptive speech is lateral to the tumor. We wanted to understand, could this be at risk when I perform the surgery? So I got a functional MRI scan showing receptive speech and word processing being posterior at the angular gyrus and the supramarginal gyrus. So that was about an inch away, not so much at risk. I then got DTI images and superimposed them on the post-contrast images, showing that all fiber tracts were displaced medially, including the longitudinal fasciculus that is responsible for speech production and speech integration. I got the DTI images to make sure the internal capsule wasn't involved. And I was able to do a lateral temporal lobectomy with resection under the medial temporal lobe and do a gross total resection in this tumor yesterday. And the patient is right awake, out of the ICU, talking fluently without compromise to speech. So last two cases is this one. This is a highly complex, deep white matter lesion and thalamic glioblastoma that came to me after the patient suffered a seizure. The patient was worked up and had this lesion on the CTA. There was an incredible amount of tumor or vessels or AVM at the same location as the tumor. We were not exactly sure whether this was simply AVM with brain swelling, but the tissue looked too abundant. So we said we need both a DSA, a vascular study, which clearly identified the AVM and shunting in the lesion, as well as an MRS, which is a spectroscopy study reflective of infiltrative tumor based on the signature that you can obtain from this imaging study. And then we decided that this lesion, this location would not be safe to resect, but we still needed a tissue diagnosis. So based on the combination of all these images, I was able to develop a stereotactic imaging tract that showed me I could get a contrast enhancing portion of the tumor that was not hypervascular on the CTA, and I could do a biopsy of highly infiltrative high-grade glioma, and the patient could at least be treated with radiation chemo for a non-resectable lesion. Last case, again, this one, multifocal glioblastoma. This is one of the cases where imaging helps us not to do surgery that may not be helpful to the patient. When you see that a tumor sits in a deep-seated area like this one in the hypothalamus, in the corpus callosum, has a satellite already high frontal, has two satellites around the MCA, both in the frontal lobe as well as in the hypothalamus, and has tumor lesions between under the operculum. In these cases, a resection does not help the patient. We have learned that we would like to help these patients to at least get a tissue diagnosis. And in this case, you can assume that the tissues are the same. So I did the biopsy of the safest area, which was the high frontal lesion, turned out to be multifocal glioblastoma. And the patient could at least go on for chemotherapy followed by radiation because he was MGMT methylated. And the patient had some quality of time based on a minimal invasive procedure. So just to summarize, modern imaging helps us to be smarter in our strategies, what is necessary to achieve maximum safe resection. If the finding is incidental and the patient is either non-eloquent from location of the tumor or eloquent, if the patient is truly asymptomatic, at least let us get an MRI scan to characterize the lesion. If the lesion is then progressive, one needs to add in at least some other imaging modalities to understand the lesion and its vascular supply. Should it come to resection, which is likely the case when the lesion is progressive. If the lesion is symptomatic and non-eloquent, you can do a simple operation where you just use the MRI scan and maybe a CTA, and you can achieve maximum safe gross total resection. Sometimes we use different sequences to delineate the tumor, but most of the time a standard MRI scan and navigation will do. If the lesion is anywhere near eloquent cortex and therefore complex in location or in adjacent tissues, I use the entire spectrum of technology to make this surgery safe and sound for the patient. And as of now, we have shown that you can achieve excellent outcomes. Thank you very much for your attention. Isabel, you're muted.
Thank you so much. This was a great lecture. And in the interest of time, I think we're going to continue on with Dr. Manish Aghi, who is a professor of neurosurgery at University of California, San Francisco, director of the brain tumor research there. He is also a former president of the AANS CNS section on tumor. And we're very honored to have you here today, Manish.
Thanks, Isabel. Hopefully everyone can see my slides. It's really a pleasure to join you today on GBM Awareness Day. I'm going to be talking about intraoperative brain mapping for glioblastoma. I think stylistically, I'm going to be covering more techniques rather than a case-based approach. And so in that way, it'll be a nice supplement to what Eckhart just did. And there will be some overlap and hopefully some time for questions. This is a topic that really could, fill an entire residency in terms of conversations, but I've tried to condense it to be brief. These are my disclosures, which are not relevant to what I'm going to be covering. I've broken this up into a few areas. I wanted to introduce to me, it's important before you talk about mapping to talk about why we're doing it, which is really to achieve what both of the previous speakers focused on, which is maximal safe resection for glioblastoma. And then, brain mapping is a tool or a technique, but it's only as useful as how much time you spend preparing. So each individual case, you don't just reflexively want to, put brain mapping in your booking and then not think about it. You want to really go into the OR prepared. So talk about preparation and then the tools. It's ultimately in a this is stimulation-based mapping, and so the electrical tools are really instrumental. And so talk about that, and then talk about motor and language mapping as the two primary modes of mapping that we use. But in concluding at the end, I'll also mention that the reality is that this is just the tip of the iceberg, and we're starting to map all sorts of functions, and the future is really quite exciting. So by way of introduction, maximal safe resection, an abundance of literature has focused on this concept that the standard of care for GBM starts with a biopsy, but ideally a maximal safe resection, so that you not only get a tissue diagnosis, but achieve the cytoreductive benefit. That decision-making has evolved over time. Work out of our institution has favored attempted resection when it is felt to be safe in the hands of the neurosurgeon, and when more than 70% of the enhancing disease can be resected, although that is nowhere near the level of evidence that Isabel talked about earlier, but institutionally that's been our practice. And then of course this is followed by treatment and then management of recurrence. But these outcomes that correlate nicely with extent of resection have been shown in numerous studies that I've cited here in the small print, but greater extent of resection impacts progression-free survival and overall survival, and then allows chemo and radiation to be more effective. And that is not the primary focus of my talk, but I want to take it as a principle that we can all assume based on this abundance of literature and the basis for which we attempt to do brain mapping. Unfortunately, though, across the globe, most patients are not achieving the maximal possible extent of resection, and the lack of availability of brain mapping certainly plays a role in that. Because when we look at the importance of brain mapping, and this is almost the conclusion slide, but I put it at the beginning to highlight how important this is, which is that this was a meta-analysis that our institution participated in several years ago, but the results have proven valid over the ensuing years. When you compare literature studies that use stimulation-based brain mapping to those that do not, what you find is that in non-eloquent locations, there's really no difference in the functional deficits, as you see here on the left, for the graph on the right, but on the left side. But as the locations become increasingly eloquent, the mapping cases shown in gold are able to preserve their rate of severe deficits compared to the non-mapping cases, where the rate of deficits begins to double or more than double as the eloquence of the brain tissue increases. So that's the good functional outcome. And then the extent of resection also gets more favorable in association with a reduced rate of late severe deficits when you use brain mapping in those cases. And so this highlights the principle of the importance of brain mapping, but also the recognition that in non-eloquent locations, it's certainly not needed. And so it's a matter of using it for the right cases, which brings me to my next topic, which is how do we prepare for a brain mapping case? So this is a wonderful and robust tool, but we need to apply it selectively so that that our patients obtain the benefits and in a case-based manner. And so the way I like to think about this is, you know, we're going to the OR with a patient and their tumor. And so you want to ask two questions more broadly. The first is, can the patient be mapped? Is their level of, in the case of the two topics we're focused on today, motor and speech function, is it good enough to be mapped? And so in the case of motor function, the mapping is incredibly sensitive. And so I certainly have used it in patients who have minimal function, but if there truly is a 0 out of 5 diffuse loss of function in the entire contralateral hemisphere, then the role for motor mapping in a case like that will be reduced. Similarly, if a patient is unable to complete the language tasks, which I'll touch on in a moment, that you will be assigning them for intraoperative speech mapping, if they're unable to complete those tasks at the bedside the day before surgery without having received sedation, then the chances of them being mappable are very low. And so that's a team-based assessment that we do with our neurophysiology team shortly before surgery. And there are certainly cases that cannot be mapped. And then we cut to the second question, which is, should it be mapped? And is it in an elegant location? And along those lines, an important consideration, but one that should not limit the use of mapping, is, will sites of positive stimulation be exposed during the resection? If you have to turn expose the entire hemisphere just to visualize sites of positive stimulation, then your tumor may not be close enough to those sites to warrant the map. And in that situation, the lack of a positive stimulation leaves you uncertain if you had the right stimulation parameters to start with. So you're essentially lacking a positive control, and you're encountering a situation where the utility of the mapping may be limited. And in fact, it's a classic scenario on oral board exams, which is the moment you incorporate a tool like mapping into a case where it may not be needed, the examiner will undoubtedly take you down the time-consuming scenarios of mapping failures and things like that to illustrate how even choices of using a technique when it might not be needed can have consequences to your patient. And then there's the scenarios where you may be in doubt. Maybe you're wondering if the tumor has displaced the pathways, or you have a left-handed patient and a right-sided tumor, and you're wondering if language may be located on that side. And so in those scenarios, preoperative imaging, as Eckhart talked about, is very important for us to determine before we go to the OR, whether the patient should be mapped, and if they are being mapped, how, what our approach of entry will be even before we bring in the stimulation. And I've shown 3 techniques here. Diffusion tensor imaging has been around for decades and generates the visualization of the pathways based on the diffusion of water molecules. Functional MRI measures regional changes in blood flow while the patient performs the tasks and questions. And then our institution has a robust MEG program, magnetoencephalogram, which measures magnetic fields emitted by active neurons via a scanner that the patient wears in a helmet. And recording, what's really nice about this is the millisecond level of resolution is really robust temporal resolution. And then MSI, when you integrate the MEG with the MRI, gives you a very good visualization of where pathways are located. These are not a substitute for stimulation-based mapping in the operating room, but essentially allow you to go to the operating room maximally prepared for what to expect. The one I have left out here is the WADA test, which is certainly still commonly used to determine hemisphere localization of language. And here I've shown some examples of DTI pathways, but it can highlight most commonly and historically corticospinal tracts, but more recently also somatosensory tracts, optic radiations, and the numerous tracts that have come to be visualized for highlighting language pathways that I've just listed here, but will not be going into detail on. We also routinely will now use postoperative DTI, which can show the rebound of their tracts to their normal location, or in some cases will show injury that could be predictive of a lower probability of recovery or resolution from a deficit. And so these scans are very helpful to illustrate your surgical outcomes and help to predict long-term recovery for patients. So finally, next to the tools for mapping, and this is all stimulation based, and this can be done via handheld stimulators. A monopolar stimulator will provide a more diffuse rate of current, but also a higher rate of detection, whereas a bipolar based stimulation will be more focal in nature and less spread. And so the bipolar presents advantages when you're at the cortical surface to increase your confidence that you're catching the location and not capturing spread. The monopolar, on the other hand, has tremendous advantages subcortically because, as I will show you examples of, it illustrates distance from tracks. And this brings me to the next important topic, which is that stimulation can be cortical or subcortical. So stimulating the cortex before you've resected any cortex will help you plan your corticectomy and where to approach the tumor from. And then once your resection is underway, you can place a electrode over that site of stimulation and have your neuromonitoring team continuously stimulate that electrode to confirm tract integrity. There are certainly caveats, as even if you are at the lowest threshold needed, sometimes that will break through sites of minor injury, but as long as there is no loss of stimulation from a cortical electrode that's being done at the lowest threshold, that can provide pretty good reassurance of tract integrity while you are operating in real time. And then subcortical stimulation, as I will talk about in a moment, warns you of your proximity to your tracts, but is less useful for confirming integrity. These tools have also been integrated into our standard operating tools. Here you see an example of a monopolar stimulator that can be incorporated into the suction, allowing for continuous stimulation while you are operating, continuous subcortical stimulation while you're operating. And this is very important because if you have to continuously switch from your tool that is removing tumor to a stimulation tool, you will not capture these events in real time. So even if your tool for subcortical stimulation is not integrated into a suction or another operating tool, you still want to consider holding it in one hand while you are removing tumor with, for example, an ultrasonic aspirator in your other hand. And so for my remaining time, I wanted to just divide this evenly between motor and language mapping and talk in a little more detail. And so for motor mapping, there's a variety of, we like to be, I've talked about this in some of the previous slides, but always cognizant of the different levels that you can stimulate. So you can have a corkscrew through the scalp that actually will give you transcranial motor evoked potentials. That is certainly the least sensitive, but can provide some feedback in a case where you're maybe a safe enough distance away for the motor pathways. And then direct stimulation, as I mentioned, can be via a cortical strip electrode or a handheld simulator that uses bipolar or monopolar techniques and can be applied to the cortex or the subcortical pathways. The important thing to touch on is being aware of the homuncular anatomy as shown in the figure here. And so your neuromonitoring team, although they are going to have responsive electrodes placed throughout the contralateral hemisphere, will want to know what sites of the body they should be focused on, as will your anesthesiologist, who may be looking for motor responses under the drapes. And so, obviously, if you're out laterally, you will be focused on face and tongue responses, and if you're out extremely medially, foot, and then in between would be more arm and hand. But always caution to the anesthesiologist and the neuromonitoring team that particularly when you get to the tracts, there is some unpredictability. And then also a reminder that these medial localization of the lower extremity isn't just all the way up to the cortical surface abutting the falx, but really extends into the interhemispheric fissure. And so that underscores the importance of stimulating in the interhemispheric fissure with either your handheld stimulator or a cortical strip electrode while you are resecting, to really work diligently to preserve lower extremity function. And similarly, being aware of the possibility of a hand knob that extends further out from a traditional strip. And so this is really why the stimulation is so important, because if you just rely on the preoperative imaging, you will not capture these nuances of where different regions are located. Subcortical mapping, as I mentioned earlier, is a very useful tool, and this is our results institutionally for subcortical mapping. And the important take-home point is that when you stimulate at the cortex, you are getting localization, and having positive stimulation is actually very important because it tells you where not to go. Once you are stimulating subcortically, you've already started taking out tissue. And so if you get a positive subcortical response, particularly with a bipolar stimulation, you may be too late. And so in our cases, when we identified subcortical pathways with stimulation mapping, this again was more from a bipolar than monopolar stimulator, it predicted an increase, nearly threefold increased risk of postoperative deficits compared to when those pathways were not found. And so this, at least with the bipolar stimulation, is an important take-home point for subcortical motor mapping. Monopolar stimulation subcortically, on the other hand, is very useful because of its wider spread. And this allows you to calculate a threshold, the lowest stimulation amplitude at which a response is elicited. And it turns out that that threshold correlates very nicely in a linear manner with your distance from the tracks at about a rate of 1 milliamp per millimeter. And so I will routinely get thresholds down to 2 to 3 millimeters with a relatively low rate of postoperative deficits, and most of those are transient. And at 4 to 5 millimeters, that rate of postoperative deficits, or 4 to 5 milliamps as a threshold, is going to be extremely low. And so this experience gives you the ability to work confidently subcortically as you get closer to the tracks. And really what we do is what institutionally is what's called trimodal motor mapping, or triple motor mapping, where you have the transcranial motor evoked potential, the cortical strip electrode, and then while you're working the subcortical monopolar and bipolar stimulation to provide you the feedback along all those different axes, because each of them is providing different information. The cortical strip electrode is confirming the integrity of the pathways throughout their length, and the subcortical stimulation is for the monopolar is telling you how far away you are, and the bipolar is providing that valuable negative result that you are not yet in a precarious spot. And so that approach really integrates everything to get the benefit of all the different techniques. So switching gears to language mapping, the way we break this down is into tasks that are going to be specific to location, but our standard battery will include counting, reading, and picture naming. We have a whole array that our team will go over with the patients in the preoperative setting to walk them through the process, not just the tasks, but what the experience will be like. And it's an iPad-based task, and these things have all been standardized at most institutions. And it's important for your preoperative assessment to identify the tasks that the patient is able to perform and exclude those that can't be performed for a variety of reasons, not just the tumor, but cultural and fluency. Not every patient will be 100%, will have 100% aptitude across these tasks. And that is very important to narrow them down. And then mapping of multiple languages routinely done in patients who are fluent across languages. And I've routinely encountered cases where we've had to adapt our operative plan to preserve one language, even though the other language would not have been affected by operating at a certain site. And this is quite routine and increasingly common in the multicultural world we live in. The anesthetic considerations for language mapping, again, could fill an entire talk, but in brief, our institutional practice is to use monitored anesthesia care, combining local anesthetics with a low-dose infusion of dexmedetomidine, propofol, and remifentanil. And the way some people will describe it as a sleep-awake asleep, the idea being that the patient is sedated, but then awakened before opening the dura so that their breathing, which will pick up once they are not sedated, will allow a degree of ventilation or hyperventilation to relax the brain before you open the dura. And then the patient is then awake to perform the cortical tasks. At that point, once the cortical mapping is completed, although historically we called it asleep, awake, asleep. That notion does predate the routine use of subcortical mapping. And so there is a decision making, but typically we will allow the patient to rest again after the cortical map while the initial corticectomy is made, but we will work with our anesthesiologist to let them know that we may need them awake again for subcortical language mapping, and give them a time frame during at which time we will need them awake. And for subcortical language mapping, I keep it extremely focused, and really, not doing the entire battery, but focusing on the tasks that may be most relevant to where we are. Sometimes it can just be a matter of having a patient do one task routinely while you are operating. Depending on the location, it's going to either be picture naming or reading. Another thing I did not mention for the cortical portion of the awake language mapping is that I routinely will do electrocorticography so that the stimulation threshold I'm using cortically is the highest threshold at which we are not obtaining after discharges, because we want to minimize the risk of a patient having an intraoperative seizure during awake language mapping. The electrocorticography, historically, we used to do via a crown that placed electrodes throughout the brain, but we've since simplified it to just placing 2 4-contract strip electrodes at the opposite ends of the exposed brain, and that obtains sufficient information about whether the patient is experiencing after discharges, which can be a precursor to a seizure. You want to also have ice cold saline available for these cases to irrigate the cortical surface if there's propagation of an after discharge on those cases. It's very important to be thorough on language mapping because the areas of positive stimulation can vary considerably across patients. And here you see an example of areas of speech arrest filling the entire inferior frontal gyrus on our institutional series from Mitch Berger, areas of anomia also similar, and then alexia more focused, but certainly naming and general speech arrest across tasks like counting was quite variable. And so as a result, here you see an example for a case of mine where we're placing numbers across the entire inferior frontal gyrus and superior temporal gyrus for mapping, and that represents the 2 locations that we will most commonly focus our mapping efforts on. But you're basically spanning from the both sides of the sylvian fissure to the posterior aspects of the sylvian fissure as well. And so I think I've run up against the clock, and so I just wanted to conclude by really summarizing what to me are the 2 most salient points here, that considerable evidence supports the benefits of maximal safe resection for outcomes in our glioblastoma patients, which is really why we've all gathered here today, and that the addition of brain mapping for motor and speech mapping has improved our extent of resection while minimizing long-term deficits. And lastly, I should say that ongoing work is focusing on the mapping of other tracks, including optic radiations. I did not yet include that because it's certainly not standard practice institutionally. And I think where this work really could benefit, and you can stimulate and find a variety of pathways, but we really need to get to the point for those things that we are with motor and language, where we can use the stimulation to tell us, okay, now you have to stop because in a few minutes you're going to be in trouble. And so that's really the next step for those other things. But that future is already here for motor and speech mapping. And so I think it's really important that we increase our incorporation of those techniques in the cases where it's going to benefit. And so with that, I will conclude and thank you for your time.
Thank you so much. This was an amazing tour de force, taking us through a academic life worth of work and more. And you're really showing that perseverance and technique is important. Thank you so much, Manish. In the interest of time, we're going to move on with Professor Drummond. She is the Director of Neurosurgery at the Royal Melbourne Hospital. She's also former president of the Australasian Neurosurgical Society. Kate, thank you so much for waking up exceedingly early. I know that you're neurosurgeons and neurosurgeons get up early, but this was extra early. And joining us today within the executive committee, Professor Drummond is the co-chair for the global neurosurgery efforts that we lead.
Thank you, Professor Germano. Thank you so much for having me. You can see my slides and hear me?
Yes, we can.
Great. So we've really heard from the previous speakers some fantastic work that if you're in community practice or perhaps thinking about starting a subspecialty brain tumour and glioblastoma service, it might seem somewhat daunting as to how you get to that point. And so I'm going to talk a little bit about multidisciplinary, and I've added a bit in there with research-led care for glioblastoma and how to build your team or how to build your service so that you can start providing the best care for your glioblastoma patients. So I'll start just by showing you this is where I work. Many of you might not know Melbourne. So our cancer hospital, general hospital, women's hospital and university over here. Although that's much like many US institutions, what most people are actually impressed by is our ballpark. Although of course that's not for ball, that's for football, but that's our ballpark. So when we're talking about treating glioblastoma patients, we really want to hit the sweet spot of this nexus of clinical care, research and education. And I'm leaving the little education bit off today, but I'm going to talk about great clinical care, how you build up a great team for clinical care, and how you really can use research to add to that and to build your team, because that adds interest, it adds cohesion, it adds collaboration, and it allows you to build a very cohesive team. So what are the basics of building that team? And I think the important thing is to see this as an incremental exercise. And I'll show you exactly what I mean by that. But you know, you really need a multidisciplinary team and a well-functioning tumour board. You can add in the advanced surgical and imaging techniques that we've just heard about. You should really start some form of data collection, because that then gives you a base for reviewing your results and for doing research. You should think about tissue banking. You should think about clinical research, and particularly laboratory links, even if they're not in your institution. You must pay attention to supportive care and to bringing your patients into the way your service works. Clinical trials are a great galvanizing force, and this will bring you to excellent clinical care for your glioblastoma patients. So when I said incremental, I've shown a picture here. This is me and Mark Rosenthal, who's Professor Mark Rosenthal, who's the head of medical oncology in my institution. And that was my multidisciplinary team when I came back from Boston. So Mark and I in 2 rooms in the outpatient department. That was the multidisciplinary team. And that was the tumour board and the clinic. So subsequent to that, by recruitment and scraping together bits and pieces of salaries here and there, we've now got a team that includes many neurosurgeons, trainees and fellows who, of course, always push you forward, medical oncologists, radiation oncologists, a neurologist, pathologists and radiologists. Psychiatrist is now a routine part of our multidisciplinary team and tends our tumour board and our clinic, a care coordinator, obviously skilled nurses, and we try and get the researchers and the laboratory scientists into the tumour board and into the multidisciplinary team. They sometimes even attend clinics so that they can see patients, and that really gives them a different perspective to what they're doing. So we really try and get the PhDs and the scientists into our team, and occasionally we even have a vet neurosurgeon that brings a dog brain tumour along for us to have a look at for general interest. So now we've got a great big multidisciplinary team. And I think one of the real driving forces, if you can possibly set up a program where you can get some fellows, they really move your work forward. They bring great interest from overseas. These are my current fellows. So Dominican Republic via Israel, Sweden, Poland, and the United States. So, you know, managing to get those fellows really pushes your work forward and brings great color and collaboration to what you're doing. Oh, I'm going the wrong way, sorry. So how does our tumour board run? We actually run it maybe a little bit different to how everyone else does. We don't review every case. an absolutely standard glioblastoma that's had a good resection and is going on to standard Stupp protocol radiotherapy and chemotherapy is just discussed amongst the treating clinicians in the multidisciplinary clinic. We discuss controversial cases or those for which there's genuine discussion or equipoise, which keeps it interesting rather than just scrolling through a bunch of standard cases. Anything where the molecular data has thrown something up, anyone who might have a clinical trial option, and it's got a really strong educational focus. We stop and we ask our scientists or our psychiatrists or our fellows or our trainees questions so that we can really build interest, make it fun for everyone. But I think the really important part is that we make it almost compulsory that people attend these regularly, because this really normalizes behavior. The surgeons who may not see glioblastoma as their primary focus can really be educated into the importance of, say, using adjuvants in surgery, of gross macroscopic resection. And so I think it's really important to make sure that everyone in the unit is on the same page. Then adding in advanced surgical techniques, and this is a very important part of my team. You must get yourself a very good neuroanesthetist. So this is my neuroanesthetist, and I use an awake technique. But I think a awake craniotomy is one of those things that you can add into your armamentarium pretty easily. I mean, you know, you saw from Anish some pretty advanced techniques, but you can do your mapping much more simply if you need to. And so this is a technique that you can bring in to really move your practice forward pretty cheaply compared to a lot of other things. And so an awake surgery, which really gives your patients the option for a better outcome, I think is a really important thing to bring in. From there, I think if I was building a neurosurgical service and building a team, I would move on to 5-ALA, because although the drug is expensive in the overall cost of a craniotomy and for the for the proven benefit for gross macroscopic resection, I think that that's important. And then really expensive things like, you know, we've eventually managed to get ourselves an IMRI and the ultrasound. Well, the evidence for that is really not fantastic. And so if you can't afford those sorts of things, don't worry. You can still provide great care to your patients. So building your team, in introducing advanced surgical techniques. And I think a real fundamental part of things that will build your team for you is to start to collect data, because that will start to give you a research focus. This is our database, nothing fancy about it, but and anyone who wanted to avail themselves of this program, it's not that we've got no proprietary interest in it, but it means that you can start collecting data for your patients and start collecting, you know, the outcomes of their, in a prospective way, outcomes of their multiple surgeries, their adjuvant therapy. And this has been really great for us to give us, to start writing some good papers. So these are just a few over the years: tumor-associated epilepsy, metastasis, socio-demographic factors for our brain tumor patients, histology, seizures, clinical trial participation for glioblastoma patients. We can really look at what we do and what it means. And so that's a really great way to galvanize your team. And so we've been collecting that data now for more than 10 years, and that gives us a great corpus of information. The other data that we started collecting a little bit, not quite so long ago, was the quality of life outcomes of our patients. And that has now really led to a very big practice in how to improve our team by having a look at what these outcomes are for our patients, and made some pretty nice publications. If you can, I think it's, you know, we have a saying in our tumor board, it's against the Geneva Convention to remove a piece of tissue and not bank it somewhere so that it can be used for research in the future. If you can start collecting tissue, then, you know, this is a great way of building your team. And the really important thing is you've started collecting the data. And so now when you take the tissue out, you've got clinically annotated specimens. And so much of what is banked is just, you know, really just the tissue without a lot of data about what's happened to the patient. So this is really important. We find it very useful to have it based around a project. If you've got a reason for a researcher, and the reason I've got this picture in the corner here is this is intraoperatively, this is the hands of one of my PhD students waiting patiently for her little bit of peritumoral brain, where she's doing patch clamping of glioma cells around the core of the tumor. So if you've got a project where the scientist even comes into the operating room and takes the tissue with them, that really really kickstarts your tissue banking. There's nothing more demoralizing than banking a whole bunch of tissue and no one using it. And to really bring the scientists in to what we're doing so they can see what we're doing and they can see what tissue and what might be available for them, we started a weekly brain tumor research group meeting. And that's really the same crowd as the tumor board, but starting that meeting meant that the scientists come, we might have supportive care research one week, we might have, hard molecular biology the next week. It really allows us all to be on the same page as what we're doing and has made a big difference to our team, but it's got a real clinical and translational focus. I've just put this here because you need to be thinking about what your supportive care program is for your part of your team, and that's often a brain tumor nurse or a care coordinator. In Australia, where patients often travel hundreds of miles to come to their care, we've started developing an online supportive care community for Australian glioblastoma patients. That's got both an information repository, multiple communities, because you might be the only person in your town with a glioblastoma or a low-grade glioma, or the only mum with a tumor, or the only retiree. And so we can create networks of people in similar situations online, and also a toolbox to look at things like cognitive behavioral therapy for sleep that can be all done online. So that supportive care can be as simple as starting a brain tumor support group, or can be as complex as really starting a comprehensive program. If you can then integrate clinical trials into your team, there's a really good reason to do it. Our research and others show that if you have a patient in a clinical trial, even if they're on the placebo arm, they do better. And our data would show that so this is that survival for patients not on and on a clinical trial. And you'd say, oh, well, that's just because the clinical trial patients are younger and fitter. So no, it's actually controlled for age and performance status. And it shows that these patients, including those that were on a placebo or just a first time in human, so not even a drug that we might even get to a dose that is of any use, those patients do better. So if you can incorporate that into your practice, and that can be difficult, but if you can build a team that can do a clinical trial, that's really important. And as we all know, doing that and going through this situation, going through this process is very difficult. So you need to think about which trial. We try and have a trial for each of the tumor types in our institution, but just you could pick one to start. And what you want to think about is, is the protocol and are the investigators in your unit able to do this trial? And often just tacking on to a multi-center international trial is the right thing to do to start with. Do you have someone who can do the approval process, the IRB and all the site-specific approvals, because that's what will make you lose the will to live? Do you have the right patients to recruit? Will you have enough patients to be able to recruit after you've done all this work? Who's going to review the data and do the statistical analysis? Often in multi-center trials, this is done for you. And then presentations and publications will follow. So you want to be very careful. Obviously, if you're new to clinical trials, you don't want to, put your hand up for a very complex surgical trial, perhaps with convection enhanced delivery or something that's very complex. You might want to just put your hand up for, a fairly straightforward drug trial. We've made a niche market in first-in-human trials because that's something that we can do very easily, and some perioperative trials. So to conclude, if you build a robust multidisciplinary team, just starting from the basics and then adding on all of these components as you go, but building the team is really the key step in excellent glioblastoma care, which is what we're all here for. It can be incremental and it benefits patients, but also it benefits health professionals and the researchers. So it really makes it a more engaging and rich place to work, rather than just beavering away on your own somewhere in a room without that team around you. And it normalizes and elevates your practice. If you can embed research into your clinical practice, it'll improve your clinical care and your engagement with your clinical care. And just always remembering that clinical trial medicine is good medicine, and that if your patients can avail themselves of a clinical trial, every patient should be given the opportunity to do that, because it'll be great for their care. Thanks very much.
Thank you so much. This was an incredible presentation, really important to our audience. And I would like to thank the audience. We had numerous people from North Africa, South America, the United States, and Europe. So thank you so much for joining. As we said, we had a glitch with the live streaming, probably due to the heat wave that we're experiencing in New York, probably just due to technology. But this it was recorded, so it will be on YouTube. And I have 2 questions from the audience. So one revolves around the use of perioperative embolization for hypervascular GBMs. So I will get a quick answer and then ask the panel if they have a different experience. We do not do that. I think that for GBM, it is very important to stay, if possible, out of the tumor, so to work around it, and that really decreases your blood loss. Dr. Agi, do you have any?
I don't. I've never used it. I agree with you that it's pretty rare to need like a blood transfusion or have a significant blood loss on these cases. And also I would be concerned, I'm not a vascular or endovascular person, but about, the safety of doing that, and how, because for extraaxial tumors, they can certainly access blood vessels that, they are confident are not perfusing normal brain, but in the GBM situation, it'd be a little bit trickier. Obviously there's a number of people who've proposed using those approaches for delivery of therapy, but I have not used it for embolization.
Thank you. And Kate, any comments about that?
No, we wouldn't do it. And I think, if you find yourself with significant blood loss while taking out a glioblastoma, as you say, you're not doing it the right way. You don't want to get in the middle and work from the middle around the outside. That's when you find all the bleeding. You want to determine your margins and try and stay out of the middle.
Excellent. So thank you, everybody, for participating. I would also like to thank our patients for their tenacity and for possibly being watching this today and looking at us working together with them as a team, and hopefully to continue to improve the quality and the longevity of their lives. So thank you, and have a good afternoon or morning.
Thank you.
Bye-bye.
Bye-bye now.